Shivakumar is a professor of surgical oncology and head and neck surgery at Tata Memorial Hospital. He has a special interest in skull-based surgery, oral oncology, and thyroid surgeries. He published many papers, more than 110 publications. The floor is all yours, Dr. Shivakumar. Thank you.
We'll go with the presentation on infratemporal fossa, management of infratemporal fossa. So basically, I'm going to focus on the relevant anatomy and the what surgical techniques to minimize the various complications that one might face while doing this procedure. Zygomatic arch and posterior to the maxilla. Whereas the masticator space is a facial lined space containing all four muscles of mastication and the posterior body and ramus of the mandible along with its nerve. Now let's look at this picture here. It tells you this details a bit more better. Now this is the masticator space, which has the muscles of mastication and the mandible and the structures within, whereas the infratemporal fossa is medial to the mandible, posterior to the maxilla, and it has these structures here. So the masticator space communicates with the infratemporal space, but these two are slightly two different space within. So this we need to understand. And here if you just look at it, the skull base from below, so this is the margins of the infratemporal fossa. That's the posterolateral surface of the maxilla, the zygoma, and you will have the mandible within, and the socket here, TMJ socket, and this is the pterygoid plates, and this is the posterolateral aspect of the skull base. And here you have the foramen ovale, and here you have the foramen lacerum. So this is important because you need to restrict yourself to the foramen ovale. If you tend to go anywhere, below, posterior to the foramen ovale, at a plane deeper to the foramen ovale, then you will put the internal carotid artery at risk. This is important while we do the infratemporal fossa clearance. This is again just another dimension of picture which shows what is the masticator space with its content. And we all know the masticator space division by Leo et al. Of the infra-notch and supra-notch masticator space. This was done, they drew an horizontal line at the sigmoid notch, and the space above is what they call a supra-notch, and the space below the infra-notch. So the infra-notch mandibular space disease is what really responds very well to the treatment, the surgical treatment, multimodality treatment that we offer. Whereas the supra-notch disease may not respond as well, and that is what they've shown in their article 2. And this other classification by Vijay Pillai and colleague, they've classified the T4B further. That is, class 1 is involvement of the infra-notch masticator space. Class 2 is involvement of the lateral pterygoids, temporalis above the sigmoid notch, something like the supra-notch disease. And class 3 is involvement of the pterygomaxillary fissure, infraorbital fissure, and extension into the intracranial space. So, in my practice, at least, what I find is when the disease involves the pterygomaxillary fissure, infraorbital fissure, and intracranial space, this is the class of patients which I would not offer surgical management, because of the plain simple reason that I'll not be able to get an R0 resection, and also the entry of disease into this fissure, these fissures, provides a gateway for extension of disease way beyond your surgical field. So essentially, you may not end up with an R0 resection, and these are morbid surgeries. So we all know that in oral cancers, if you're not able to give an R0 resection, the surgery done is as good as not done actually. So class 1, class 2, definitely the patient can be considered for surgery. Now, when we look at what is the big deal with infratemporal fossa clearance, why is it not considered as a straightforward procedures? Because it's associated with certain because of the intricate anatomy that we just saw here, and it's very important to understand this to minimize the associated complications. So what are the complications that you can come up with? Facial nerve injury. So what happens is when you're raising the cheek flap, when you tend to go above the zygoma for raising the free flap, it's always prudent to identify the zygomatic temporozygomatic branch and to save that branch in order to avoid this facial nerve issues. Because if you go blindly there, then you might damage that branch, and this complication is evident. The other thing is, even if you do save, sometimes when you're working near the the TM joint area, if you're not, what you've saved needs to be preserved. That needs to be constantly kept in your mind to save that structure. Otherwise, it might be damaged posteriorly. The other thing is internal maxillary artery bleeding, which can be easily identified and controlled. It also helps in minimizing your intra bleed. We'll just see a small video wherein we'll see how to do that as well. And ICA injury, again, as I mentioned, you need to stick to the plane at the level of the foramen ovale. We'll again see that in a small video. And the pterygoid venous plexus bleeding is the major challenge when you're doing an infratemporal fossa clearance. Otherwise, it's a simple, straightforward surgery. This is what really puts the surgeon, in the back foot, and we tend to worry about this bleeding, and that's why there's so much of concern. So if we can understand how to take care of this, handle this pterygoid venous bleeding, the surgery might be a bit more easier. And because most of these issues or surgeries are extensive, involving extensive resection, reconstruction, it is associated with swallowing issues and cosmetic issues as well. This can be minimized by taking due care while doing surgery and doing appropriate reconstruction. So basically, these are the things that we need to keep in mind while doing an infratemporal fossa clearance. Now, this, a picture I just saw today morning in a YouTube video, and I recommend you all to just go and see this, YouTube video, just short 6-minute video. You have the link here. I mean, maybe you cannot see it, you can just borrow it from the presentation is here. And this person just describes the infratemporal fossa anatomy so clearly and step by step, and it helps you really understand what are the structures that are there and how to deal with it. So the two knee structures this is the foramen ovale, right? And this is the internal maxillary artery going to the sphenopalatine foramen. This is the mandibular canal, and this is the lingual nerve, the mandibular nerve, and this is the pterygoid venous plexus, basically. So it just gives you some sort of an understanding as to what are the structures that you're dealing with when you're just before you go into doing this particular surgery. You can just try to understand this anatomy, and that will really help in doing the surgery properly and understanding what structures are there at what point, and then you can just handle them appropriately. Now, this is a small surgical clip wherein we'll just see a case wherein this is a 56-year-old lady with a buccal mucosa disease, polydifferentiated squamous cell carcinoma. That's the mandibular bone erosion. It's just involving the disease till the mandible till the notch, sigmoid notch, that is. And we did a upper alveolectomy with a hemimandibulectomy, neck dissection, and a free flap reconstruction. So we just a good amount of skin had to be removed because of the disease that was involved, and that you just have to raise the remaining neck flap, and then this is the anterior end. We're just raising the neck flap so that you have the vessel control before you go into the main surgery. So now we're just keeping the 1B with the specimen, and then we're just taking the facial artery, and now we are raising the upper cheek flap here. Now this is the lower end, that's the upper end. We're just taking the mucosal cuts, and the bone cut will be taken at that very particular level, at that same level as well. We're just marking it. We're not taking the bone cut at this point because it will make things difficult later. Now we're just raising the upper cheek flap. That's the level of the zygoma. That's what I'm saying. So when you're raising this flap at the level, this is again I'll just orient you. This is the cranial end, and this is the caudal end. That is anterior, and this is posterior. So now when you're raising the upper cheek flap, the other thing that we were discussing yesterday in the panel as well, that how to prevent post-operative parotid fistula, you always identify the parotid duct and ligate it at this point, because otherwise the patient will have a collection in the post-operative period and it will be giving rise to problem. Now I'm palpating for the zygoma. You palpate for the zygoma and just hug at the lower border of the zygoma and cut your masseter at that level. If required, if you want to even take the zygoma, you just have to use the periosteal elevator and take the periosteum with the soft tissue so that the zygomatic branch can be saved, and you can save the facial nerve. And so that is the zygoma, and you cut the masseter flush with it at that particular level so that the entire masticator space is removed. Now we are just delineating the posterior border of the masseter, and then this is the parotid tissue. That's what was being said, that we have to go between the parietal tissue and the mandible. Now, once that is done, the masseter is cut. Now we are going towards, that's the condyle. We're trying to identify the internal maxillary artery and take it up front. So that is just behind the condyle of the mandible, and you can easily identify it and clip it. This also helps in reducing the intraoperative bleeding. Now then, once that is done, we just move a bit anteriorly and take the temporalis muscle. All these muscles should be cut a bit higher than what you can, what you just see, so that you will get a third dimension of soft tissue margin. So we're just taking all the tissue as much as possible here, right? That's again the, now we're just trying to cut the temporalis muscle here a bit more posteriorly, and that's the posterolateral wall of the maxilla here. That's the posterolateral wall of the maxilla, and as much posteriorly as possible, you're taking all the retroantral fat pad and taking all the temporalis muscle and getting it all down. So we can take an en bloc resection. So once that is done, now we are cutting the mandible at the lower end, and then we are just taking the mucosal cut as well, and we are just having good, because the bone is eroded, you need to have some soft tissue cover as well with the mandible. So that is why part of the tongue is also taken, and this should be taken at this point because you're seeing the disease and you can have a good margin around it and have a good control. And once you're done that, then you do the upper alveolectomy. I tend to do the upper alveolectomy second, because if you do it first, then there'll be a lot of bleeding and you won't be able to control it. So once you've done this part, now we have already delineated the soft tissue here. Now we are more confident in taking the bone cut and do the ITF clearance and do an en bloc resection all together. So once that is done, now we will be taking the bone cut. So you can see almost that's the pterygopalatine fissure area, and we're just going to, we've done the soft tissue clearance at that point. We're just going to take the bone cut and take the entire thing together. And here you have to take the attachment of the medial pterygoid flush with the hamillus, or if you want to even take the lower part of the pterygoid plate, it can be done right at this point, right? So you cannot take the pterygoid plate very higher up because it is attached to the base of the sphenoid bone, the greater wing of the sphenoid. That will be detrimental. Now we're just taking the entire the masseter muscle, sorry, the medial pterygoid muscle. So that is forming the third dimension. Now here I switch to using bipolar as much as possible, and what you need to do is you need to use the suction intermittently. You shouldn't be continuously sucking it. You should give an entire clear field for your cautery to work, and that is it. If you keep sucking continuously, by the end of the surgery, you'll end up with a 2 liter or more than that blood loss. So now once that is done, we take the TM joint capsule, that is the condyle, and once the capsule is taken, I just take the entire, you take the mucoperiosteal plane there. You can see the greater wing of the sphenoid here, the skull base is visualized. You go in that plane to minimize the blood loss, because if you go through the lateral pterygoid, the bleeding will be more. You just have to keep, you can use the harmonic, but I have not used it. Bipolar is good enough. That is the greater wing of the sphenoid, the skull base. And now the last thing that will be left is the mandibular nerve at the foramen ovale. You can see the foramen ovale there, and that's the mandibular nerve. I just cut it closer to the foramen ovale. You can use a knife or a cautery or whatever you wish. That's the mandibular foramen, and you cut the nerve just at its entry point there, and the entire specimen is delivered. What we need to understand is, I just wanted to show that, okay. Just a minute. Oops, sorry. I just wanted to show as to at what plane do you have to be there to avoid the internal carotid artery there. So what I'm trying to say is, you see the foramen ovale there, and you shouldn't go deeper to that. Now your internal carotid artery will be just, that is the lower edge of the greater wing of the sphenoid. If you go well into this area, below that area, that's where you will have higher likelihood of damaging the internal carotid artery. So which is what you just need to avoid. So that was the the techniques and aspects that you need to keep into consideration while you're doing an infratemporal fossa clearance. The basic bottom line here is you need to know the anatomy. What I always stress is, when you're doing an infratemporal fossa clearance, use the suction in moderation. If there is bleeding, just put a pack, wait for some time, remove the pack, do the surgery, again put a pack if necessary, and suctioning just enough for you to use your cautery, because if there's a lot of bleeding, your cautery will not work. So you just have to do that and nothing more. The rest of it, you can use a harmonic scalpel, you can use a bipolar, but avoid using a monopolar when you're in the skull base, because it may not work as well. Thank you for your attention.
Thank you, Dr. Shivakumar, for the fantastic presentation on a very challenging area of infratemporal fossa. Dr. Rammohan Tiwari, Dr. Srinath and myself, both of us were with him for almost 10 years at Bengaluru Institute of Oncology. And he was describing this technique of mandibular swing. And we used to get a good clearance going from behind the tumor, so that you're not going in and addressing the tumor directly from above. What's your thoughts on getting clearance through that, or doing zygomatic osteotomy to go into the infratemporal fossa?
I've used the mandibulotomy for a maxillary tumor which is more posteriorly located, so that I can access the tumor first. I actually started doing that after reading Dr. R.M. Tiwari's papers. And so for a maxillary tumor, I've done mandibulotomy, approached the infratemporal fossa, done a clearance, and along with that a total maxillectomy, and then put the mandible back. But for oral cavity cancer such as this, I would prefer to do an en-bloc clearance, wherein you can actually, we need to read the scans well to understand as to how we need to approach the tumor. I've never done a zygomatic approach because, when we do this, there's not much need of that. You can just see the entire tumor, it's all under your control, so you can, get it out very well. So I'm more comfortable doing this, but I have, as I mentioned in a few situations, I've used a mandibulotomy approach described by Dr. R.M.
Any questions from the floor?
Excellent presentation, sir. This is for the residents. Never attempt ITF clearance without adequate experience, because the bleeding can be tremendous. This is what I wanted to say. And know your anatomy well. And the length of the distance of the carotid canal from the foramen ovale is about 0.8 to 1.6 centimeters. So it's not very far away. Now always keep a finger above the styloid. That is one protective thing which you can do. But when you're operating, both your hands may not be free. So that is something which you should be aware of. So excellent.
Yeah. Shivakumar, what is compartmental clearance of infratemporal fossa?
This is what was demonstrated.
What was demonstrated was just that. So we're just removing everything en bloc together.
This is phase 1 and phase 2. If, stage 1 and stage 2. If it is going into the pescal, you are not operating.
If the disease goes into the pterygopalatine, pterygomaxillary fissure, infraorbital fissure, then I would certainly not operate those patients.
On the table, is there any possibility of cancellation or approaching to those areas?
No, we have reached too far to back out from this point. Now we have to do that assessment pre-operatively, read the scans well, read it with the radiologist, and if there's any doubt, we need to think of alternate strategies. But if you're sure that we are going to get an R0 resection, there's no disease going to the pterygomaxillary fissure or infraorbital fissure, we can as well do that.
Mainly, what is the type of lesions that they are indicated for this infratemporal fossa?
So like this, where the disease is the T4, the masticator space, just abutting the lateral pterygoid, the lateral pterygoid should not be infiltrated, and it can be abutted or involved. But if the lateral pterygoid is involved, if the disease is filling the infratemporal fossa, you don't have a margin beyond that. You can remove, meaning to say you're working inside the tumor and removing it out. If it is squamous cell carcinoma, we all know that if we do that, it's a futile exercise. So if we can have the lateral pterygoid as the margin, and if it's a disease in the infranotch area, we can just get it out en bloc together.
Now, is it a buccal mucus
lesion
or a maxillary lesion?
So maxillary tumors for ITF clearance, we can do a total maxillectomy and ITF clearance without taking the mandible. Or we can do a mandibulotomy approach, which I just said, wherein you can do a mandibulotomy approach where the tumor is most posteriorly located. We can do an ITF clearance and a total maxillectomy and get it out en bloc. So mostly I do this for oral cancers. In a few selected maxillary tumors, I may use a mandibulotomy approach.
So for maxillary tumor going to ITF, would you prefer going from medial to lateral or lateral to?
it depends on the tumor and the.
Like a posterior maxillary tumor going to the pterygoids.
So
you
then
have to-
mandibulotomy approach.
Mandibulotomy.
Yeah, that would be my preference.
Yeah.
But having said that, you have to choose your patient well. If if the patient has trismus, then things will be mandibulotomy may be more helpful because it increases the
Vision.
access and visibility of the tumor of your surgery.
Any this thing on cutting only the coronoid and then
Getting
Sorry,
better.
I didn't
I
understand
agree
that.
with sir that mandibulotomy approach is the safest and the easiest and the best approach to remove the tumor in toto completely. Regarding cutting the coronoid and taking the entire ITF tissue, that can be done if the mouth opening is very good.
Yeah.
And you are able to access the tumor posteriorly. Then only you should attempt that. Otherwise, I
mandibulotomy.
agree with sir. What
But as the disease is there, what we have the paramandibular concept, even paramaxillary clearance
Is
needs to be done if
done
we are dealing
properly,
with it. So in
yeah.
that case,
posterolateral wall also, I mean, you can tailor the ITF clearance as per the disease. If disease is creeping along the posterolateral wall, you will remove the posterolateral wall. Otherwise, it's an overkill. Why do you want to remove it? Even the pterygoid plates. If you need to remove the lateral pterygoid plate, remove the lateral pterygoid plate. If you want to cut at the pterygomaxillary fissure, but that is a risky area unless you have attempted many times. I don't think you should attempt such surgery.
So when you're taking the pterygoid plates, you have to be really careful.
Careful.
Because if you go way too higher and take the pterygoid plates, you'll end up in torrential bleed. The cavernous
and
sinus might.
especially if you have a bad split going
Yeah,
into the
we shouldn't do a blind attempt. Just above the pterygoid, the two pterygoid plates, maybe less than a centimeter is what you can take safely. Above that, it's going to be a blind venture which should not be attempted.
2019, I won't take the surgeon's name, an incident happened in TMH when one of the residents used this to cut at the pterygoid plate. The patient became blind because the fracture line passed through
going
the
to the
optic.
I think that is something which we need to be extremely careful. We get the same problem with Lefort 2 and Lefort 3
The patient
osteotomies.
was blind.
You use the curved osteotomy and you need to direct it downwards,
Down,
not
yes.
above.
Yes.
Otherwise,
It's
the
actually
base of
mentioned,
skull fracture
posterior
happens.
inferiorly the direction should be
Always use a curved osteotomy, never use a straight osteotomy, and the direction of the curve should be inferior.
inferior.
So
Posterior
that the-
inferiorly is mentioned in
The,
all
the torque
textbooks.
of the hit it goes down, not above.
And a very gentle tap.
Very
Yeah.
gently tap.
Yeah.
One more question I have for you, Shiva. Pterygoid plexus bleeding for the youngsters who are here, that's a dreaded. Whatever you try to do, it oozes. What's your trick of stopping?
So, as I mentioned, one is you can take the internal maxillary artery to begin with. That helps in minimizing the bleed. Despite that, the pterygoid venous bleed will be there. And while you're doing the surgery, you use energy devices. Bipolar cautery is what I routinely use. You can use the harmonic scalpel as well, but I'm not sure if it is any better than a bipolar itself. Bipolar works really well. Avoid using suction continuously, because before you realize you would have had 2 to 3 liter blood loss just while doing that ITF clearance. And if the bleeding is too much, you're not able to use your cautery with good control, just stop the surgery, just put a pack, wait for 5 minutes, and then go back in. You get another 1 minute before the bleeding again, increases. By the time you can get a clearance, then again wait, then do the clearance. So by this, you can actually minimize the blood loss, and you can have a 500 ml blood loss only when you do an ITF clearance. Otherwise, you'll easily end up having 2 to 3 liter blood loss. So we need to take care of these basic things. There's no, and don't panic. If you're really not overwhelmed because of the blood loss during the surgery, just call for help. And its help is not far away. There'll be somebody who will be there around, and because you're also mentally exhausted and you're overwhelmed with the situation, your mind might not think properly. So I always say this to our residents: if you have a problem, just put a mop and call for help. Just don't keep working in that pool of blood. You'll end up doing more damage than actually doing anything better.
And quickly remove the specimen, because as long as the specimen is in situ, it will keep on bleeding. So, and avoid that what sir told, avoid using suction too much. That is the tendency of the resident to keep sucking. So the bleed will keep on sucking the blood. And
I've done that mistake. It's not that I've not
all
done
of
it.
us have done that.
I've done that mistake, and
All.
I've learned from my mistake that we should not do that. So I'm just sharing my experience.
Now, how are you packing this area?
Just a mop, sir. Just a mop, pack it, and once the specimen is out, the bleeding settles. So you just have to, during the procedures when the bleeding happens.
Is there any need of putting surgical?
At the end of it, the foramen ovale the thing is you have the accessory meningeal vein which retracts, and then you cannot bipolarize that. And sometimes there'll be some very annoying bleed that comes from the foramen ovale, which you cannot control with just a bipolar. So at that situation, what I end up doing is just use bone wax to obliterate that, use Surgicel and Abgel, and just pack it. Pack it, wait for 5 minutes, it just settles down. And then you have to use your reconstruction. If you're using a PMMC, and if there's good amount of muscle, so the lateral muscle is what I use just to pack the ITF, whatever little that can be done. If you're using a free flap, we just have to tell our plastic surgeons to pack that with either the vastus lateralis, or then they do the ALT most of the time. They de-ephthalize and just pack the ITF with that. And when we are doing it with plastics, I tell them don't disturb the pack that I've kept there, the Surgicel and the gel foam that I've placed, not to disturb that, because you remove it again starts bleeding. So just have to pack it, and then it works.
Yeah, the Surgicel comes really handy in the end when all the tricks have stopped. And what we do is, like, there'll be surrounding tissue, you buttress that tissue on top of the Surgicel, so you have a pressure for the Surgicel when all the tricks and praying for God, everything.
Put your finger on there for half an hour, that's it. Most of the times it stops.
After you've done an ITF clearance, there's hardly any tissue left there. Ideally, it should not be left because you want to remove everything there. So you just have to pack and then use the free flap or whatever PMMC flap tissue is there just to pack.
So for ITF reconstruction, we've been using ALT in a different manner these days. We do a chimeric ALT in which the perforator which supplies the skin paddle, we use it to resurface the lining, and on the distal runoff we are taking extra muscle and we pack it into the cavity. So the results have been actually good. We've done 22 cases so far. Yeah.
To Dr. Girisha, so which is a good case to do zygomatic osteotomy in case of ITF tumors, and when we get trismus after this, what is the best situation to get out?
I think if you have some of these skull-based tumors, mainly we are talking about chordomas and nasopharyngeal carcinomas. Those are areas where in NIMANS we have been doing. We do a lot of zygomatic osteotomies and go in. Trismus, I think you should take the coronoids out. That is something, both coronoids, if you take out, then the possibility of your mouth opening being better is definitely there.
Thanks.
Thank you.
Thank you, Dr. Shivakumar. Superb presentation.